Okay, everybody, we're live. Russell, I'm going to live stream now.
Great, Monica, we are live and ready to start.
Thank you, Kylie. Good morning and good afternoon for those of you on the East Coast. Thank you so much for joining us today for our colorectal cancer town hall. This town hall is brought to you by the Mayo Clinic Center for Health Equity and Community Engagement Research. So today we have several speakers that will be speaking today and talking about their experience as a survivor of colorectal cancer and also experience as a provider of care for colorectal cancer patients. So we first have Kellyanne, who is a 10-year survivor living in Jacksonville, Florida. Diagnosed the day after her 32nd birthday, she remembers thinking, what if I never turned 33? She credits her cancer journey with giving her a new outlook on life and a desire to do good in the world every single day. Julie is joining us from the far north of Minnesota, and she is here to share her cancer experience. And finally, we have Dr. Timothy Woodward, who is a consultant in the Division of Gastroenterology and Hepatology at Mayo Clinic in Florida and joined the Mayo Clinic staff in 1994. He is an author, lecturer, and founder of the Advanced Endoscopy Practice at Mayo Clinic Jacksonville. He has much expertise in GI oncology. So now we will turn it over to Kellyanne, who will talk with us a little bit about her experience. Kellyanne?
Sure. Thank you so much, Monica. I appreciate that. So as Monica shared, it was just days after my 32nd birthday. And I had noticed some symptoms and thought things were weird. And I had recently relocated to Jacksonville from up north. I had worked for an incredible hospital in Washington, D.C., and had lots of friends in the medical industry and doctors and connections. And my friends were saying, you need to go to the doctor. And so, I called a primary care doctor. And again, I had just relocated, so I didn't really have an existing relationship. But I made an appointment and I started communicating with that doctor. You're 32. I'll never forget, someone said, wow, you've lost some weight. And I think I was flattered, right? Because at 32, you're like, well, that feels good. And coupled with some other symptoms, and I had seen blood in my stool. And I had some trouble with nausea and just, holding food down and feeling okay. And that's really what it came down to, is like, I just didn't feel okay. Well, I went to a new primary care doctor and had an exam and shared some cell phone photos. And she was alarmed and she said, we're going to need to do some follow-up. I didn't really know how alarmed she was because she seemed pretty calm and okay with it, but she called me the next day, and unbeknownst to me, her husband was a GI doctor, and I apparently became these two married doctors' dinner conversation. And if you believe in serendipitous moments or, things are meant to be, this was one of those moments. So I pretty quickly, with their help and advocating with my insurance company, I had private insurance at the time, and at 32, it's not a guarantee that you can just walk in and get a colonoscopy or an endoscope. So they helped me get through that process, and I was seen pretty quickly. And it feels like it was a wild ride, but you can remember all of it like it was yesterday. So after that first procedure and colonoscopy, and biopsies were done and they ran some tests, I was given the news. And I was given that news with a, wow, you're so young. And I thought, like, what does that mean? And I'm sorry, but it's so hard to relive sometimes. I immediately demanded a second opinion. And I actually flew home to Massachusetts and was like, I don't believe this. Like, I'm going to go home to Boston and I'll see another doctor and they'll tell me something different. And ultimately, I was told to go back to Jacksonville and listen to your doctors. This is all, in fact, true. And you need to do everything they say. And that new attitude towards life happened right then and there. I returned to Jacksonville and chose a treatment plan and met with multiple providers. I was able to actually go with a friend out to Arizona and meet with a Mayo Clinic nutritionist who really helped guide me through a really great nutrition plan during treatment and after treatment. And it just changed my outlook on every day-to-day activity. I looked at everything I put in my body differently. And I wanted to enjoy every single day like it could potentially be my last day. So after having the adenocarcinomas removed and the growths removed, I went through 6 months of oral chemotherapy. And I continued to work every day. And it was hard, but it was truly a blessing that, you think, I don't feel right. Like, that's what doctors are for. And the team of doctors that I was blessed with were incredible. It's wild, but it's 10 years later. And from a survivor's perspective, it's still scary, but I don't ever want it to change the way I live. I turned 40 during the pandemic and put off having my first mammogram. And my primary care doctor kind of berated me and was like, nope, we're not doing that. You need to go. And of course, the standards were really different because of COVID. I had to go alone. I had to, kind of sit alone with no support. And it was scary, but it was necessary. And of course, you hear that like, oh, you need to have more tests done. We might have found something. And you start to have that like stress and anxiety. And luckily, all was clear, and I continue with all my routine screenings, and, I stay in close contact with my doctors. But I do credit that cancer journey with changing the way I looked at everything from nutrition to product packaging to the way I, took care of myself and managed stress. And I am forever grateful for that team of medical providers that helped me through that. Thank you for letting me share my story today.
Thank you so much. Thank you so much, Kelly, for sharing. Next, we will have Julie, who will share a bit of her experience. Oh, actually, I'm sorry. Next, we will have Dr. Woodward, who will do a brief presentation to talk a little bit about colorectal cancer.
I thank everyone for having me come on board. My name is Dr. Tim Woodward, and Kelly, I appreciate your story, and it's home to me because I have a very good friend whose son was 32 when he was diagnosed with colon cancer. I think your story is a good segue as to what we don't want to happen. And what I mean by that is this: you had unfortunately come to us with symptoms. And when there are symptoms, that means that generally the cancer is present. What we want to try to do, and what I'm going to talk in this brief period of time, is the importance of screening. I can't stress the importance of that, as you've encountered about your physician berating you about your mammogram. Screening catches lesions early, and particularly with regards to colorectal cancer, it can catch it even before it becomes a tumor in the form of polyps. And so that's, I'm going to spend a few minutes talking about that, as well as sort of mechanisms to hopefully kind of prevent or have a preventive outlook. Can you see my slides?
Not quite yet, Doctor. So,
Okay.
so click on that, and click on share.
Over here. And
So in Zoom itself, there's that screen share button on the bottom, and then click on that and then choose. You can choose screen 1 or screen 2. You should be able to see which one is showing your PowerPoint.
okay. You have
And then
that one?
click on, and nope, and then click on there. It's coming up now. Yep,
Perfect.
we're good to go. Thank you.
Okay. So no risk. And a few things I want to sort of stress at the start from this. Overall, there's a lack of awareness, at least the pandemic kind of sort of could have cut on that, because we saw sort of awakening knowledge with regards to colorectal cancer because of the youth that are involved. But then the pandemic sort of blew everything out of the water, and we'll address that in a second. And lack of knowledge of the screening and benefits. That's another point that I want to stress, and then we'll talk about how we do that. And also because it's involving the netherworld, the lower regions, there's fear and embarrassment as well as discomfort with the issue of screening. So those are the sort of things I'm going to sort of address. A few things you need to know. It's the third diagnosed cancer, second cause of cancer death. 1 out of every 19 people will develop colorectal cancer. That's amazing. That means in a classroom that at least 2, in a class of 40, at least 2 people will have that to consider. Now, the good news is that because of screening, the incidence and the death rates have decreased with regards to colorectal cancer, at least within the appropriate populations that we normally see it, as people over the age of 50. However, as I mentioned earlier, it's increased in populations under age of 40. We can attribute the decrease in death rate and the decrease in cancer due to the fact that we have screening measures. And with those screening measures, we have polyp removal, and that polyp removal allows us to basically remove the cancer before it gets started. Now, I've mentioned about age and such. Other key factor that comes into play and probably accounts for what we're seeing with the younger populations is that we're seeing a high, when we look at our diet and lifestyle, there's a high contribution of both those goes into the mix of not just colon cancer, but multiple cancers. In particular, diets high in red meat, as well as processed foods are an increase. And there's been some talk too about how our animals are sustained by antibiotics and hormones and such that may well be contributing to the picture with regards to cancer in this population. I want to talk a little bit though about the behavioral risk before we get into some of the more germane issues with regards to how cancer comes about in this regard. So what do we mean? Physical exercise. Now, Kelly, I can see is thin. I'm sure she's taking really great care of herself, but for the large majority of people, particularly over the age of 45, lack of physical exercise and obesity contribute to the formation of cancer. How that occurs, what we're finding fascinatingly is that we know that certain aspects of fat cells are actually cancer promoters. And that's one of the issues. Smoking across the board, not just colon, lung, breast, pancreas, all are sort of contributory causes into the development of colon cancer and all the other cancers. Diabetes. People with type 2 diabetes, that's the non-insulin dependent, are at increased risk as well. That has to do with some of the growth factors that are produced by the state of being in diabetes. And that, again, as a growth factor, sort of promotes the development of cancer. Now, more germane to also what we're seeing in younger populations, and be interested in what Kelly has experienced in this regard, is that we're beginning to see more now with regards to risk-linked cancer due to genetics. What I mean by this is that what we're beginning to see is that at least now 30–40% of cancers may have some genetic roots, and as we expand what we know about the human genome, we're seeing that more actions are being contributed. Two of the ones that are sort of classic are FAP, that's familial adenomatous polyposis, and the HNPCC, which is another form of genetic cancers. I bring that up is that particularly now with younger populations that get cancer, one of the, and again, this is an aside, the best patient is the informed patient, and you are your own best advocate. And so, in particular with the younger patient who develops cancer, ask about gene testing because it impacts not only you, but your children and your siblings too. And I want to just sort of touch just briefly about the types of cancers that are there. That's an adenomatous and then the flat lesions. And the reason why I want to do that is that this is where we come into how cancer is detected. Here that you see before you is an example of a flat lesion that we really didn't know much about until the early 2000s. And through new techniques and such that have been developed, we're able to make that flat lesion one that's removable as well. Again, in the old days, people were treated with surgery. Now we can do a lot of this endoscopically. Now I'm going to just spend 5 minutes, because I know I have a tendency to try to put so much in, but this is so important, about colorectal cancer screening guidelines. The primary goal of colorectal cancer screening is colorectal cancer prevention. Here's a sort of graphic illustration of what I'm talking about. Scope, scan, or stool. What this relates to is that the two measures that you see, the stool picture as well as the scan picture, are examples of detection-only studies, but they're so germane, particularly with regards to stool study, because it's so accessible. This colon CT scan it's kind of fallen out of favor because you have to still go through the prep and everything else. And so you might as well just bear the discomfort of doing the prep and go to what is the sort of gold standard, which is the scope. Now, the key thing about this is that I say gold standard, but it's still, even with colonoscopy, 5 to 10% of lesions can be missed. But the advantage of the colonoscope is that it can remove polyps early. And as we mentioned, removing them early is the way we get rid of the cancer as it progresses. The other point I just want to get to, because I don't want to take up this whole time, and we can have plenty of time for questions afterwards, is I'd like to elaborate a little bit more about the testing. So I mentioned that colonoscopy is sort of the end game, meaning that what I mean by that, and here's the picture for that. I want to make sure you have that on your screen about the colorectal cancer screen. End game in that we do that study if any of the other studies are positive. In particular, what I'm referring to now is the FIT test, which is the fecal occult blood testing. FIT is different from the occult blood from prior to 2000, where now we have immuno detection of human blood within the stool. And the Cologuard, which has been a major find in turn that works on the basis of the genetic abnormalities that are detected in the cancer that are sloughed off in the stool. The key thing about the two FIT and the Cologuard is that there's no prep. You put the stool in a container and we assay for that. The frequency of testing for each of those will be, as far as the fecal occult blood, once every year. The Cologuard is once every 3 years. The colonoscopy, if normal, is once every 10 years. Again, the benefit of the colonoscopy is that is the end game. The FIT or the Cologuard will tell us that a polyp is or cancer is present and that you should have a colonoscopy with that. It cannot be an ostrich putting your head in the ground. Once the test is positive, it needs to be addressed. And I think I'll stop there. We can talk a little bit later about some of the other nuances of colorectal cancer that I can at least address as a gastroenterologist.
Thank you, Dr. Woodward, for that information. And so, I took some notes as you were talking, and it sounded like, lifestyle modifications and genetics play a huge factor in colorectal cancer, and that we really need to remember to scope, scan, stool in terms of screening, and that there are some options. And, we'd love to be able to share that slide of the different options, the FIT and the Cologuard and colonoscopy, with our audience afterwards. So we'll be able to get that information. Thank you so much. So our next speaker is Julie. And as I mentioned earlier, Julie is joining us from the far north of Minnesota, and she is going to share her cancer experience story. Julie?
Good afternoon or morning, depending on where you are. Dr. Woodward, thank you very much. That was a fantastic presentation. As a person who has been through cancer, which I'll share in just a moment, that I would have appreciated you much more than I do at the moment about 8 years ago, before I had gone through this journey, because they're very wise words, and I can't second everything that you said more than enough. So I actually am in far northern Minnesota. I share that because most people forget that. And I live in a very small town currently. My digit population is 3 digits long, and it begins with a 5. So it's a very small rural community, but my story didn't begin there. Actually, in 2015, I was living in Phoenix. I was very healthy, very vibrant, had no health issues, was living what I thought was my best life. And one crazy day, I was walking and I stepped wrong, just one wrong step, seemed normal, and I broke my foot, which seems unrelated, but it was my right foot, and it put me on a 2.5-month no driving, having the world take care of me because I couldn't do anything on one of the little scooters. So during that time, I decided I should catch up on all the things that I hadn't been doing and taking care of. And one of those included a colonoscopy. I had just turned 50 years old, so it was kind of on my screen, on my checklist to do and to take care of. So we had made the appointment. It was in June. I didn't have obvious symptoms. It wasn't that sort of thing for me. It was just kind of, I was going to go in and I was going to check my box and have it done. So I arrived. I'm going to give you some dates just so that, because they're kind of interesting, I had my colonoscopy on June 11th in 2015. And I remember waking up and seeing my doctor come in, and big smile on my face, kind of waking up, thinking I'm checking the box, and I'm looking at him, and it's super serious face. And I'm like, everything good? And he looks at me and he's like, no, Julie, it's not. You have cancer. And it's like, I wasn't even completely awake yet, but to have that arrive, and then he had then explained to me he'd already been on the phone with an oncologist, and then your whole world spins, and then it starts. So very quickly, I saw a physician, and I had a CT. I saw a physician. Diagnosis was all there. It was very clear that I needed to have surgery. It was adenocarcinoma as well. For me, it was rectosigmoid. And I had no polyps, just cancer. I think that's kind of interesting. So I'm assuming at some point I had a polyp that turned into cancer. And he also explained to me that he tattooed the inside of my intestine for the surgeon down the road, which I think is just an interesting point to share, because I had never had a tattoo, and my first 2 tattoos were actually to mark my tumor. So July 9th, which was less than 30 days later, I actually had a Da Vinci, which is the robotic assisted resection. It took a fair amount of time, but it was very successful. And I really look at myself as that if you're going to have colon cancer, that's kind of the way you want to have it, because from the day I was diagnosed to being on the other side and being cancer free, I was less than 30 days. And I was just like, wow, that was an amazing way to go through the experience. And not that it was not lessening any of it, because the trauma is there, the stress is there, all of the things that come with that experience. And I did all of my follow-up with my doctors. I went and I had all my blood work and my screenings at that point in 2015 in Phoenix. Adjunctive therapy and chemotherapy or anything afterwards was not recommended. I was type 2. They felt that they had handled it, that I was in good shape. So I actually moved on with my life, continued raising my kids, running a business. I actually got married again and to my college sweetheart, and moved to northern Minnesota. So that's how I went from Phoenix to Minnesota, was living the transition and my whole new life. And then actually 3 years later, it was December of 2018, I woke up one day and I just didn't feel right. I didn't know why. I didn't understand it. By the end of the day, I was in so much pain. I couldn't sit down, any of those things. So we ended up in the emergency room. And they were thinking maybe I had an anal fissure or something like that. They had no idea. I was in so much pain. The CT showed that I actually had a new mass. They couldn't tell me at the time, very small regional hospital, but it was one where I was immediately referred to physicians and surgeons and that whole piece, that I actually had surgery within a couple of days because my new tumor, they use a word called spiculated, which means star-shaped. And it was going in 10 different directions. It actually was in the area where I no longer had colon, but I had a tumor that was wrapped around my ureter. So it had actually shut off and was killing my kidney. It was within millimeters of several vertebrae and just really wreaking havoc all over my pelvic cavity. So I had surgery to stent the kidney and hopefully they could save it, these sorts of things, and really walked into a space in December that I spent December 31st with my husband sitting in the oncology office here locally. And with him saying, Julie, even though we have a really good cancer program, we can't help you. That what you have is complicated and you need to, we need to refer you. So your choices with where you are you can go to Fargo, North Dakota, which is 3 hours away. I could go to Minneapolis, the Twin Cities, which was 5 hours away, or I could go to Rochester at the original location of the Mayo Clinic, which is 7.5 hours by car from my house. And we spent that Christmas that year discussing our options and where we were going for treatment with Anna Christmas and being really scared and kind of going, I'd been through my cancer experience, here we were. And now it was back and it was not the 30 days and easy done experience. I was going to have another cancer experience and this one was going to be way harder. We very quickly made the decision that Mayo is where we wanted to go, even though it would be the hardest for us to get there and to travel and the distance and to receive care there. It was just an automatic yes for us. So we made a conscious choice and we chose to have a Mayo experience. And I can't tell you how important that has been, all of the care members on my team and as things progressed and how many people were involved. We very quickly were seen by the team. Within a week of calling, the appointments were made and my case, you learn very quickly that there's lots of people involved with Mayo in your care. And when they take you, because of how they triage, and which is really a cool thing that Mayo does, they actually, my appointment was set with the director of colorectal cancer, which I very quickly learned was kind of the heads of department take the most complicated and the hardest cases. So it was like, I was really glad I was in the best hands, but there was part of that was super scary for me too, that they coordinated my care, they established a plan. It was, for the first time, you also learned something else with Mayo, and that's the term big surgery, that there were 7 actually surgical teams involved with my surgery because it was so complicated. I also did not require specialized chemotherapy and radiation that had to be performed at Mayo beforehand. So Mayo worked with my local providers. So I actually was able to handle the chemotherapy and the oral chemotherapy along with radiation. I did 5 weeks, I did 25 treatments here locally, which is still was an hour drive every day for 25 days. You guys know, some of you know what that's like. Those that don't understand that the snowplow angels here in northern Minnesota, I did this in February and March, and I blessed the snowplow drivers every day with the clear roads that made it possible for me to do that. My surgery was actually in April of that year. I got a little bit of break in between, but the surgery was, I was there a week beforehand, and it was meeting with all of the providers and all of the questions and all of the things that happened. There was going to be aftercare that had to be involved. So I had people that were taking care of that. It was just, I was the center of attention of a lot of things, and it wasn't the way I wanted to ever be the center of attention. That's not my world. So surgery came and the day was there. And if I can offer anything to anybody that is going through the experience, is to allow your family and friends in, and to actually allow your care team to include mental health support. That I was going to lose body parts, and things were leaving, and my body would be changing in major ways following the surgery, and having that support up front made it much easier through the journey itself. That after surgery, surgery was an entire day. I also had something, it's a phrase that maybe Dr. Woodward can speak to this. I had IORT, and that is interoperatory radiation therapy. So during my surgery, when I was still open, you actually have a highly concentrated dose, so they could give me that 25 days worth of radiation actually on the tumor area where they had removed the tumor while I was still open. So I had radiation again during my surgery. And then following that, it was expected to be probably a 5-day hospital stay. I had some problems and I ended up in the ICU, and my stay was a lot longer and complicated. And I finally got home. It took my family 2 days to get me home because of the pain and trying to travel those 7.5 hours. And the journey, the next part of the journey is I spent 110 nights sleeping in a hospital bed in my dining room with my husband sleeping in the adjacent room on the sofa. I had home care and nursing. I couldn't walk, the complications that came from the surgery in addition to the surgery. So, and then the pain. The pain journey was probably a really big part of it. And I had a tremendous amount of support is really what I want you to understand. And my best friend at the time, who had seen me through the first part of my journey and all of the lead up to this, her name was Rachel. She's actually a naturopathic doctor. 3 weeks after I had surgery, she actually was diagnosed with colon cancer. And we began 3 months later, following some of the recovery, we began our chemotherapy together, that the exact same drug. She was a week ahead of me. And it was really something to imagine your best friend having the same affliction that you do, and that you're going forward, and that's not the experience you would ever expect to share. And I even remember her talking about the things that happened. So she was kind of like the things that I could expect that might happen next with the adjunctive chemotherapy that I was going through. And we made a lot of plans for the future on what it was going to look like when we were both on the other side, and what we were going to do. The sad part of that story is Rachel and I did not have the same outcome. I lost my best friend 3 months later to colon cancer. It's still an emotional moment. So understanding that I actually drove to Portland and got to spend 8 amazing, beautiful days with her as she was home in hospice. And I knew when I hugged her and kissed her goodbye, it would be the last time I would see her. And she was gone 7 days later. So coming back home and stepping back into chemotherapy and finishing out at that point, I was only a couple of months into every treatment that I went to. Everything that I experienced was not only on the coming on the other side of cancer and healing from cancer, but it was also the grief and the awareness, and in many ways the gift of understanding what it's like for those that don't walk the path of healing on the other side of the cancer experience. So I am now 3 years later. It was 2.5 years of physical therapy to learn to walk again. I did lose some body parts, including a kidney and a number of other things that were related to how the tumor was affected. But I'm also standing here. Yesterday was the 3-year anniversary of my big surgery. So the fact that I'm standing here and that this timing came up to be able to speak to you, to show you that cancer can be very scary, even when it's not once but twice, that there's always the fear that it will come back. And I lived through that. And I want to show you that you can live through it too. And I live a very productive life now, that it's taken time to build my life back up. because the recovery journey was really hard. But I can tell you, I am a cancer overcomer, not the survivor mentality that a lot of people. I wanted to share that just because my perspective, I think, is a little different. Never once during any of my cancer experience did I feel I wanted to, I didn't go to war, and I wasn't in a battle. I wasn't fighting with cancer. That my very dear friend Rachel, who I shared with you, she gave me a perspective that I just want to share. And that is that if you in understanding cancer cells, and maybe Dr. Woodward could speak to this as well, cancer cells are part of your body. They're not something foreign that invaded. They've just, very simply put, they've forgotten, they're cells that have forgotten how to die, and then they multiply and they grow, and they're not in their normal life cycle. So Rachel really helped me understand that this was part of my body, and that it had created this, but if I could really love that part of my body and have that understanding that these cells forgot how to die, and that was where I needed to help my body. And that was the relationship that I was going to have with cancer. It was the experience of cancer is what it became for me. And how I think is a lot of that is that attitude and understanding that every day is a gift. And I'm very blessed to be sitting here and to be able to share this story with you. And thank you for hearing me, and get tested. Get tested. I am a poster child for that, Dr. Woodward. Thank you.
I want to just interject real quick. Julie, I'm going to steal that, what you said about cancer. This battle is not the, because there are cells in our body, and that we're constantly producing cancer cells. And I won't elaborate on that too much because there's so many other questions that not come up, but understand that we always are making cancer cells, and that the body itself actually polices and destroys these cancer cells. And sometimes, as you say, there are cells that just don't know when to stop. The body is overwhelmed, or it loses that ability. And so I think that's a good way to think about it. I'm going to steal that from you.
Thank you.
Thank you so much, Julie, for sharing your story. Dr. Woodward, I wanted to just go back to something that you mentioned earlier in connection to Kelly about, a family connection, or, a lifestyle intervention. And Kelly, I know you wanted to make some comments on that.
Yes, so incredible story, Julie. That was so moving. So unlike Julie, I was single, and I really didn't want a lot of people to know about my journey. And so diagnosed in September, and I had to go home in January again to Boston for my grandmother's funeral. And I decided to share with my family what was going on. And my paternal aunt, so my father's older sister, who at the time was 65, shared with me that when she was in her 30s, so more than about 30 years prior, she had been through some illness and had to have polyps removed and had to go through some testing. But of course, that was in the late 80s, I think, if I'm doing the math right. And she lived a couple states away and didn't feel like that was something she should ever share. And it really changed my family's outlook. I'm like, we need to talk about these things and be more open and honest. And I have sisters who all decided that, they were going to start, advocating for themselves, and no matter their age, go and get screened and tested to make sure that, there maybe wasn't an underlying issue or something that hadn't caused any symptoms. Because like Julie, it's that, you just don't feel right, but you're not going to like run out the door and say, I think I have cancer, someone test me. And I touched on, and I saw that there was a question about this. One of the big lifestyle changes for me that the Mayo Clinic really advocated for through nutrition guidance. So I am actually the daughter of a butcher. So, traditional old school, works in a butcher shop in Boston, Massachusetts. And I can't remember a day where I didn't eat red meat. And when I shared that with the nutritionist about the things that were on the table for me throughout my entire life, and anytime I was at home and the foods that I prepared, I will never forget, reading all about red meat and how it affects the body. And it's not that, I am not going to tell you I'm a vegetarian by any means, but it really did give me a whole new outlook on what I put in my body and what it's like a famous athlete says, junk in, junk out. And I have a little boy that plays sports and he always says that to me. And I have read every book on nutrition, from Eating Right for Your Blood Type now to the Mayo Clinic diet. And I found a great balance, but what we put in our bodies became so important, even just for me through my, half a year of oral chemo, making sure that I kept the medicine down and I could go to work and try to have some sense of normalcy. Because again, I was a single woman. And I didn't have family around to, take care of me or make sure life was okay. And I lived on anti-nausea medication if the foods I were eating weren't able to, try to control some of those side effects. So very important. And I also just want to say, I didn't touch on this, but the mental health care is extremely important. And 10 years later, I am still in touch with my mental health counselor that helped me through my cancer journey, because I think I would have given up if it weren't for that individual.
Thank you, Kelly. Dr. Woodward, we have a clarification question. So someone in the audience is wondering, when you mentioned about increased overall antibiotic use, did you mean that increased overall antibiotic use to treat infection increases colorectal cancer, or is it the antibiotics and hormones in meats that increases?
The antibiotics and hormones in meat. And just for a point of digression, first with regards to the hormones, again, to sort of build on what Julie was talking about cells that don't know when to stop, hormones sort of act like that. I always explain to my residents and fellows that cancers are caused by one of two ways. Either, think of it as a car, either the brake is gone, so you put your foot down and you don't have a stop, or the foot, something's holding the gas pedal in. And hormones, you can almost think of as that, quote, gas to the cell. The reason why we talk about it in meats is that everything is sort of related or contiguous in the world, really. And so what you ingest, you're still going to be ingesting hormones, even though they're, quote, in the meat itself. You're still going to be ingesting the antibiotics. And the thing about antibiotics that's key and that we're learning now has to do with what we know about the gut microbiome. What's projected, this is not really fully established now, is that this thought is that the hormones alter the gut microbiome, and that in itself may contribute to the development of cancer.
Thank you, Dr. Woodward. So there's another question about screening and screening guidelines. So as you see the incidence of colorectal cancer increase in adults under 50, is that leading to any changes in screening guidelines in terms of age?
Very much so. And I think this is pretty well established now within the medical communities, is that the screening age had been 50. But now, because of people like Kelly and the actor who played in Black Panther, finding diagnoses much earlier in life, and also data to support it, it's been moved to 45. Now, another point I want to stress, which kind of relates a little bit to what Kelly was talking about with her aunt having had cancer, is that if you had come to see me back in '94, we only knew of 2 types of cancers that had a strong genetic component for colorectal cancer. That was, as I mentioned, FAP and HNPCC, or what's called Lynch syndrome. What we know now is that there's a whole gamut of genetic abnormalities that can lead to the development of colon cancer. A case in point, in which I think is important to keep in mind, is that, again, everything is contiguous, everything is related, is that there's the BRCA gene, which we see in with regards to breast cancer, also has some input on pancreas cancer as well as colon cancer. So again, it's very important to keep that family history. And I want to echo what Kellyanne said earlier about sharing the family history, because what might seem unrelated can contribute to the point, which is the next corollary of what I said earlier about 45, is that if you have a strong family history, particularly given the age at which you're diagnosed, we say anywhere from 5 to 10 years from that index time, you should have your screening test.
So another question that we have is regarding Cologuard. And so, is Cologuard testing adequate? Is that enough?
To answer bluntly, yes. And what I mean by that, and then I put on quotation marks, the air quotes. It is the best sort of screening test that's non-invasive as of now, but nothing is 100%. When you look at the literature with regards to missed lesions, Cologuard misses anywhere from 7 to 8% of lesions that could be there. And that's just, we'd all love to have 100% sensitivity, but that's not the case. What's important about Cologuard, and that conceptually, when you think about how it came about, it kind of sort of adds impact to how it works, is that what you're doing is you're picking up these cells that are shed throughout the stool, because that's the nature of things. That, you have stool going through, rubs against the tumor, and those cells have genetic abnormalities that are subsequently detected, and by special tests, when we look for these genetic abnormalities, which in of themselves actually follow a sequence that you keep accumulating these abnormalities, a cancer develops, and that's how the Cologuard works. And so it's very sensitive, not 100%, and it's certainly a good foundation so that if you do have a positive test, you have your colonoscopy.
Excellent, thank you. And I think, Julie, I think you have a comment about relationship of testing. And so can you please expand on your comment?
Yes, it staying definitely in line with what Kelly shared, and also what Dr. Woodward, is that having been through cancer twice, and there was no colon cancer in my family. There was actually no cancer in my family whatsoever. So I have the distinguishing mark of being the first one. And as such, I have 2 children in their mid-20s that because they are obviously genetically connected to me, their screening date will be much earlier. Assuming if they were to have symptoms, it would be sooner than that. But recommended first screening for them at this point in time is 40. And I think that with what Dr. Woodward is talking about also is that, and Kelly, that when we have conversations with our family and our friends, but especially our family, that if we know somebody or have a relative, especially a close relative, that has had colon cancer, that we need to understand that we actually need to pay more attention to how often, or maybe if we haven't been screened yet, we might want to consider asking for a screening earlier than what would normally be recommended for a healthy person.
Thank you for that. And Dr. Woodward, what is there any advice on what patients can do to be advocates for their health, so that if they do, have a bit of a family history, or they need to be screened earlier than suggested, what can we as patients do?
Be pushy. And I say that in all fairness, is that you are your own, I'm going to say it again, you are your own best advocate. And there are guidelines that need to be adhered to. And if your physician, your primary care doc says, no, I don't think so, I don't think you need it, present him the data. And it's hard for him to argue with what's present. You need to get them to address that point. So be your own best advocate about getting your screening. The other point too, which is important, which kind of relates to what Kelly was talking about in terms of what Kelly unfortunately demonstrated, is that her young age. This is kind of a relatively candid conversation you need to have, but ask about, I'm not saying that you insist upon it like you do with screening, but ask about genetic counseling in this regard, because 32 is extraordinarily too young. I mean, there's no age that's right for cancer. But at that age, the balance is more on the side of a genetic abnormality to account for it rather than environmental. And with that, there are certain genetic tumors that or disease processes that can lead to the cancer. Now, let me give this in full disclosure. There are issues with genetic testing that are beyond just the gene test itself from the medical standpoint. One is about the issue of insurance paying for the test. And most importantly, what happens if the test is positive? How does that affect your insurance rate? So these are a lot of issues, but at least you can talk with a geneticist to see whether in your state these things are covered and what impact does it have upon your insurability.
Thank you. And so we have time for one more question, and this is related to colon cancer health disparities. And so, Dr. Woodward, if you have any comments about what are are there particular logistics or resources or policies that need to be put in place to eliminate some of the disparities? And if you've seen anything successful that has been done to really increase early colorectal cancer screening for African Americans?
Very, very important. And again, this is based not on just feeling, but also about what the data shows. African Americans are at the highest end with regards to development of colon cancer. It has a lot to do with what we call epigenetics, genetic predisposition, but that epigenetics are that sort of midpoint between what you're born with and what you do to yourself. Do to yourself, again, is diet, et cetera. So there's even some thought now that moving from 45, that for African Americans, we need to move to 40 for screening, but that's still being bandied about. Importantly, is the preventive aspect that needs to be done, particularly in terms of diet and activity, that's exercise. And also, again, being your own best advocate. A lot of times, a physician will say, well, particularly primary care, might not be as engaged with this as I am, because that's my area of interest, but you can bring it up and say, I'm 40 years old, African-American, at least what do you think about me getting screened earlier? Put the onus on the physician to at least think about it and discuss with you what should be done. Another point too, I want to make stress is diet. Kelly and Julie had alluded to this about trying to be more holistic. If you approach the physician back in the 90s and early 2000s, we kind of would raise our eyebrows, but we do know now that diet is one of the major components in terms of prevention. There had always been the push for a magic pill. I've seen it evolve from vitamin C to antioxidants, B6, et cetera. What kind of is holding fast now is that turmeric seems to be a very appropriate and non-toxic regimen to use, as well as the fish oils. I think omega-6 is the one. I'm not being an advocate for, this is what you definitely have to take. But again, do the research, be your own best advocate, and you'll see that there's literature to support that.
I'm talking and on mute. Thank you all so much to our panelists and to our audience today. This was a wonderful discussion, really about colorectal cancer and being an advocate for your health. We especially want to thank you, Kellyanne and Julie, for your transparency, for your courage and strength of sharing your experience and being an advocate for health and prevention and screening. Thank you so much for joining us. And for Dr. Woodward, we thank you for your tireless efforts of trying to close health disparities gaps, trying to address colorectal cancer in our community. This has been a wonderful forum, and we thank you all for being here. And to our audience, thank you for taking time out this morning and this afternoon to learn a little bit more about colorectal cancer. We will send the information about about the different screenings out to all registered participants, because we do have your email addresses, so we will get that information out to you all. Again, thank you so much for participating today. We look forward to seeing you at our future Cancer Town Hall meetings, and we hope you enjoy the rest of your day. Thank you.
Thank you.
Bye for now.